I wanted to give you an example of a stepwise approach to managing asthma. So I have the document, the guidelines for the diagnosis and management of asthma, uh, as a document that you can use. And a stepwise approach to managing asthma is recommended to gain and maintain control of asthma in both the impairment and risk domains. These domains may respond differently to treatment. So for children in this document, it tells us to see figure 11, classifying asthma severity and initiating therapy in children. So this is figure 10, but let me go down to figure 11 because these are all the figures. So if we got to find it first. There's a sample record for monitoring the risk domain in children. So you could keep a record of what your patient's on in terms of long-term control, significant exacerbations, long-term control, potential risks associated with corticosteroid therapy. And I don't know where, let me just, I'm just sort of trying this to find that figure. Oh, there it is. Let me see if I can rotate this view. Rotate view, let's see, clockwise. Okay, so here's the classification right here now. I have to, but you can see the classifying asthma and severity and initiating therapy in children. So let's, as we've discussed, we've got the classification are intermittent and then persistent mild, persistent moderate, and persistent severe. So if you have this graph, you can just look at it and you can go down to components of severity, impairment, and then risk. So you can go through the symptoms, and for intermittent, it's less than 2 days a week, and it gives the age as mild and moderate. So you can walk through that and classify, where your patient is, and then you can go to the stepwise approach to initiating therapy. Okay, so that would be the next table. So let me scroll right down to here. So let's say you wanted to start just at step 1. So at step 1, intermittent asthma, children ages 0 to 4, you'd start with just a short-acting beta agonist PRN. So that's just basically your albuterol. Then slow dose, step 2, you'd add a inhaled corticosteroid. At step 3, medium dose of inhaled corticosteroid. Then you'd add a long-acting bronchodilator, maybe a montelukast, which is a leukotriene receptor agonist. But you can see how that jumps up. The stepwise approach it helps you and assists you to make clinical decisions. So this is a good starting point when you're new in practice. If you're working with an asthmatic, okay? So, and that gives you children down here ages, let's see, 5 to 11 years. The notes over here, I'll read a couple of them. Let's read under the children 5 to 11. The stepwise approach is meant to assist, not replace, the clinical decision-making required to meet the individual patient needs. If an alternative treatment is used and response is inadequate, discontinue it and use a preferred treatment before stepping up. Theophylline is a class that is a less desirable alternative because of its need to do serum monitoring. It talks about step 1 and 2 medications are based on evidence A, which are defined at the beginning of this document, which evidence A is the highest amount of good evidence. Step 3 of inhaled corticosteroids and inhaled corticosteroids plus adjunctive therapy are based on evidence B for efficacy. But you can see, I don't want to read all this for you, but that's a good place to start when you're looking at your case studies. Go to these graphs and start where you're going to go, and then you can look up your drugs for dosing in terms of what is weight-based dosing. Then here's the graph for use 12 up into adults. So you've got that. So you can see you got some numbers for pulmonary function tests here, which include like FEV1s and FEV1 FEC ratios. And I'll scroll back down here a little more. And then it's stepwise approach there. And let me just rotate this view again to see what we're looking at. This is talking usual dosage for long-term control medications. So let's look at one that we commonly use. So inhaled, let's look at a short-acting because we use short-actings a lot. There's long-acting, but just let's say short-acting. Is it going to be here? I mean, long. So this is the last one. It should be the first one. There we are. Inhaled short-acting. So albuterol. Dose applies to albuterol. 1 to 2 puffs. 2 puffs. You don't see a lot of lev-albuterol. It's not much more effective than albuterol. I think it's more expensive. And then you see 2 puffs here, and potential adverse effects: tachycardia, skeletal muscle tremor, hypokalemia, etc. Apply to all 4 short-acting beta agonists. And then nebulizers. You can set people up on nebulizers, meteor dose inhalers, whatnot. So these are great tools here if you just use them.